Good evening, everybody. It is my honor to introduce the speaker for today, Dr. Richard Cash. Dr. Richard Cash is a senior lecturer on global health at Harvard T.H. Chan School of Public Health. Dr. Richard and his colleagues conducted the first clinical trials of oral rehydration therapy, ORT, in adult and pediatric cholera and diarrhea patients at the Cholera Research Laboratory in Bangladesh. One of the major interests of Dr. Richard Cash is scaling up health programs, and he is the senior editor of From One to Many, Scaling Up Health Programs in Low-Income Countries. He has also documented the scaling up of the Brac ORT program, a simple solution. As a member of Brac Health Group, he and his colleagues have documented the Brac TB DOTS program in making tuberculosis history community-based solutions for millions. It is pertinent to mention at this juncture that one of every 100 children in India does not live to celebrate the fifth birthday because of diarrhea, and India accounts for a quarter of the world's TB burden, and on average, 1,000 persons approximately die because of TB every day in India. Dr. Richard Kash worked with Brac on their OTEP, which taught over 13 million mothers and caregivers how to prepare and use ORT in the home using the pinch and scoop method. It is estimated by WHO researchers that each year around 500 million packs of oral rehydration solution are used in more than 60 developing countries, saving over 60 million lives around the world. And in 2006, he was the recipient of the Prince Mahidol Award, and in 2011, he received the Price Prize for Improving Health. It is our pleasure to hear from you today, sir. We extend a warm welcome to you in this public policy talk series. I would not take any more time in keeping everyone who are waiting to hear from you. Over to you, sir. Thank you.
Thank you very much for those kind introductory comments. And it's a pleasure to be back in Bangalore, however virtually it might be. I was there in early January to give some talks at a workshop at St. John's. So it's nice to be back, even though virtually. I thought what I would do is to look at scaling up of health programs, and also as embedded in this is how incentives were appropriately used. And what I've chosen to use this as to use the Brac experience as a model for what might be, what has occurred, and what might be. And I hope that this will generate a lot of interesting questions. So let me start by, let's see how I need to move this forward. There we go. So who is Brac and what is it? It turns out Brac is the world's largest NGO with over 100,000 employees, and both in its workforce and its outreach. It began in 1972 in post-war Bangladesh. The mission has always been to work with poor people to bring about positive changes in quality of life through a holistic approach, a very pro-poor and a very strong focus on empowering people. Sir Fazli Abed, who just passed away in December at the age of 83, was very fond of saying, small is beautiful, but big is necessary. They are in over 70,000 Bangladeshi villages with expenditures of over $1 billion, of which 80 to 85% is generated by Brac itself. They are also in 11 countries and have been rated the #1 in terms of quality and so on NGO in the world. As a disclaimer, I should note that I am on the board of Brac USA and have been associated with them in various guises since its founding in 1972. Now, let me just start out by reviewing what the lessons for scaling up are. First of all, it's multidimensional. You need to commit to scaling up from the very beginning of a program. So you have and you have to have an institutional vision. In this case, it's to alleviate poverty and to create equity. It's important that pilot programs with relevant research and evaluation be carried out, and workers are trained prior to the scaling up, not as an afterthought. Management needs to be appropriate, very down to earth, and strongly supervised. Evaluate, adopt, and advocate, and consider a more realistic long-term frame. Oftentimes people think in terms of 1, 2, 5 years. They think in terms of many years. So the first program I'm going to try to give some idea of how these come together is the Brax DOT program for TB treatment. Now, DOTS is short for Directly Observed Therapy, short course for TB treatment. It's the standard used throughout the world, including India. When they began their program, they faced two problems. One, how do they identify cases early? Because the longer someone is not identified, the more likely they are to spread the disease. And since this treatment of DOTS requires 6 months, there was a lot of people who would drop out as soon as they started to feel a little better. And the concern here is that drug resistance would develop with people dropping out early. So the challenge was how to identify cases of tuberculosis in the community, not passive, that is, where people would come to the clinic because they were feeling bad, but active, going out into the community and actually identifying cases to ensure that treatment was begun early and that treatment was completed. So it was begun, and both of these examples are historical, but are ongoing, and so I think it's highly relevant. It was begun in 1984 and 85, which was their trial programs in a sub-district with a population of 220,000, using what were called and are still called Shastik Shebekas, a village-based volunteer. Clinical cases of TB were identified using a very clear algorithm. That is, someone had a chronic cough, maybe a bloody cough, loss of weight, and so on. And this was done through active surveillance. So these Shastik Shebekas would visit houses as part of their otherwise routine and identify cases. And then they would collect sputum specimens. The diagnosis at that time, and even now in most areas, is through staining of the sputum and looking at the microscope. And then they provided a community-based treatment, directly observed treatment. So what was the program? Well, it was based on door-to-door service by the Shastik Shebeka. So she went to the house itself to provide the drugs. Now, here is one of the innovations, and I hope we have some discussion on this. To participate in this program, the individual had to put up a financial bond prior to treatment, or about 200 taka at the time, around $3 US, which was returned on completion of treatment, less a fee for the worker, but forfeited on non-compliance. And there were very clear guidelines as to what was non-compliance. If you stopped taking the medicine and you didn't give a reason, that would be considered non-compliance. Now, treatment was never denied because treatment was always available at a government facility, which was within a certain distance from the village. The Shastik Shebeka got a small incentive for finding cases and completing the treatment. Supervision and quality control was carried out by another group called the Shastik Kormi, who had 10 Shastik Shebekas under her control. And there was then a further layer of evaluation and supervision by another level up. There was support both from government and from donors, and I will explain that. So the requirements of a bonding system: one, it has to be community-based. Treatment is generally delivered by non-professionals, since you don't, although it could be ASHA workers, certainly. The community or program contributes the bond if the patient is too poor. So no one is denied treatment because of a lack of money. So the community, generally, Brac did not contribute to the bond. The community put up the bond if the patient was too poor, so that nobody was denied treatment. Treatment is clearly combined with education, because the Shastashabika goes to the house and also inquires as a member of the community what is happening. There's a reliable backup healthcare system to handle any complications. So any complication would be referred. And there's frequent supervision and excellent management. So who is the Shastashabika? She's a health volunteer, usually around 35, with children selected by the villagers. Literacy is preferred, but not absolutely required. They're trained to recognize and treat common diseases, such as diarrhea, acute respiratory infection, including TB. And they also sell and distribute certain other products, such as material for headaches and so on, and things of that nature. They provide basic healthcare services to about 300 households, or around 1,500 individuals. So here are some pictures, and I use a lot of pictures in this. Here is a Shastashabika in an urban slum area, having collected sputum and labeling it to be sent for testing. Here is a worker giving drugs to somebody in the community. The worker is the one with the bag. And again, she's observing the individual taking the medicine. So for the first few months, it is directly observed therapy. After that, then a week supply is given, and so on, after the person has been habituated into taking the drugs. They come together usually once a month for a few hours as a refresher course. And here's a group of Shastashabikas who have come into a Brac center for a continuing education. This is a picture from Afghanistan. Brac, one of their countries that they also do work in is Afghanistan, in addition to Sierra Leone, Tanzania, Uganda, Kenya, and so on. Here, it is given through a pharmacy, where again an individual is treated right there. And later on, they set up TB dots corners in some of the hospitals and clinics, again, where this was distributed. What are the results of this program? Well, and these are older data, but it's held true. 92% cure rate, about 0.3% failure, 4% death. Now, this is the next, is very, very important. Only 1.3% default. So over 98% are staying in the program. The cost is lower than the Ministry of Health. In 2006, the National TB Program and Brac expanded DOTS to cover over 100 million people, with 78% case detection and treatment success up to 94%. Now, what factors then contributed to the success of this program? And this is true with many of their scaled up programs, not only in health, but in agriculture, education, their graduate program in microfinance, and so on. You learn from a pilot program with independent research and evaluation. Brac has a whole department called Research and Evaluation Division, which is separated from the rest of the organization so they can act independently. In this case, the involvement of community health workers was very important, with an incentive system for case finding and completed treatment. The patient provided a bond for reliable services because the drugs are free of charge. So nobody is paying for drugs. The only thing that they're paying for is the services provided by the Shastashabaka. The treatment is simple. It's right at the doorstep. There is strong management and the availability and use of external technical assistance. So if there are problems, that is bumped up the system and other advice is given. In fact, this program was an outgrowth of a program that was advised by a Japanese consultant and who helped Brac set this up from the beginning. Let me now move to another program called OTEP, or the Oral Therapy Education Program, which again features an interesting management tool. Now, diarrhea was and remains a major health program, although mortality from diarrhea has come down globally very dramatically, and in Bangladesh and in India. In the 1970s, when we were beginning work, or late 60s, when we were doing work on oral rehydration therapy, diarrhea was the major cause of child mortality, accounting for 25 to 30% of deaths. The development of ORT, oral rehydration therapy, cut costs dramatically because up to then, rehydration was done with intravenous fluid, which was generally not available in rural areas. And so treatment was now available in the home. The challenge, however, was how to effectively teach mothers to make and use ORT, ORS is the solution, in the home. That was the challenge. So how do you do that so that they don't have to come to a clinic? And I'll give you some examples as to why that's not valuable. So I'm going to give you a whole bunch of pictures here I know you're not physicians and necessarily done work in health, so I'm going to give you a bit of background here. So here's a child who's severely dehydrated. You can see the eyes are sunken in the head, and there's back in the head, there's sort of an apathetic look. Now, again, going back in time, 50 years, people would come into the clinic via country boat. And therefore, they waited a long time. And by the time they got to a clinic, if it was available, the child would be severely dehydrated. There was a rural ambulance system like this, but it was not very often used. And you can imagine trying to bring somebody across a bridge like that, which was all over the countryside, Bangladesh being laced with big and small rivers throughout. And if you looked in clinics during the diarrhea season, you would see this bed after bed. These are all little pediatric beds of children getting intravenous fluid. These were the children who could make it to the clinic. Most of them, in fact, didn't. Just to show you a piece of appropriate technology, because ORT itself is appropriate technology. This is a cholera cot. Cholera is the most severe of all diarrheas, which can lead to the death of a person within 6 hours. And what is this but simply a jute cot with a plastic sheet covering it? That sheet has a sleeve which goes into a bucket. And cholera patients evacuate up to a liter an hour. And so they die of dehydration. It's like taking a grape and making it into a raisin, or a plum, making it into a prune. And what this allows you to do is to easily collect the fluid and to replace that fluid quickly with intravenous if the person is in shock, or oral therapy if they are not. This individual just came into the hospital, was treating with IV, but then would be switched to oral therapy. So here's a woman who enters the hospital severely dehydrated. You can see it in her face. She is receiving oral rehydration therapy because she's alert and can do it. And within 6 to 12 hours, she looks like that. From this to this. It's remarkable. Here's a little girl in a rural treatment center, again, severely dehydrated. But in this case, you note that the mother is providing the oral solution to the child. And this is important because she's learning how to use it. And the child, of course, is much more trusting of her, given that she's a mother. And here she is, again, a few hours later. From this to this. It's quite remarkable. The first large-scale use of this was actually in the Bangladesh War of Liberation, when 10 million refugees passed into India. This is right near Salt Lake, outside of Kolkata. A construction site was underway, and people literally lived inside of these sewer pipes. And of course, whenever you have a mass gathering of individuals, diarrhea becomes a major problem because of water and sanitation issues. And cholera broke out in these camps, but they were able to dramatically keep the mortality down through the use of oral therapy. Dr. Dilip Mahalanobis and his colleagues in Kolkata led that particular effort. Now, the issue then becomes, how do you get this, though, into the home? One thought was, well, let's put these salts, which are simply sodium chloride, sodium bicarbonate, glucose, and potassium chloride, into a packet that could then be mixed in the home. And here are some attempts to do that. And here's a school teacher who has the packets, and he's giving them out in the village. But there is a problem here. One of the problems is, will women trust a man who is distributing this? Now remember, we're going back 50 years, 45 years in this. And the second major issue is the size of the container. Now this is from a picture from Guatemala, but you can see there was no standard container, and there was no standard container at the time in rural Bangladesh, either in terms of glasses or in terms of other containers. So you could make a container for people and distribute it along with a packet, but that itself would cause distribution problems, both the packet and the container. In this case, this was a 1 liter container. That was the size of the packet. And so actually the director of Brac, Sir Fazli Abed, working in his kitchen basically, figured out that a pinch of salt, sodium chloride, and a scoop of sugar, in this case we would probably use gur, which is prevalent throughout, but so is sugar. A scoop of sugar in a liter, about half a liter, or a seer, half a seer. This would lead to a solution that was similar to what was being distributed in the packet. Now, to get this to the home, they set up a program where a OTEP worker, the woman in green, would go to the home of a mother and teach her the oral therapy method. And they, over a period of 5 or 6 years, they reduced the message down to 7 points, if she could remember these 7 points. You still have the issue here, however, of the size of the container. And you'll notice that the worker carries with her this tin cup. The mother then brings out a container that she has in the home, that white pan. The worker then fills up her cup, pours it into the pan, scratches a line, and the mother now has her own container, a half-a-liter container. And you notice, unlike a clinic or so on, the child is sleeping. There isn't the chaos that occurs with mothers and children and so on in a situation. This is done right in the home. And she shows her how to do it. And she actually she tastes it and the mother tastes it. In the early days, it was quite interesting that oftentimes mothers wouldn't necessarily trust the worker, thinking that maybe she was a family planning worker and this was just a ruse to get family planning in. But the worker then tasted it herself to show the mother that this was perfectly fine. So the mother could now determine what it tastes like. They expanded the use of the message to the men as well, because men oftentimes would decide what type of therapy would be used for the child. And so, though they weren't taught how to make it, they were taught within the village community. It became clear later on that you could teach 4 women at the same time, as this worker is doing. And you have an added benefit in that at the time, this is less so now because all these children would be in school, but here are all the children looking in, and children, of course, remember these messages better than adults. And so you're educating both the mothers and the children. Now, a very interesting, innovative, I believe, management tool was inserted here. What was the purpose? The purpose was to educate mothers or caregivers on how to use the solution. So how do you evaluate your workers? Well, they decided that they couldn't evaluate them necessarily based on the use rate, because that would be unfair, because the mothers might choose not to use it. But if they did use it, they clearly would remember how to use it. So what they did is they decided to evaluate the workers based on what the mothers learned. So the mothers were to know 7 points. An evaluator would come to the community about a month or 2 later, after the worker had been out there and they knew which communities each worker had gone to, and take a sample of the mothers. Let's say the worker had seen 10 mothers a day and worked for 30 days. That would be 300. So a sample of 30 would be taken. The mothers would then be asked the 7 points. If she knew 6 or 7 points and could prepare the solution, it was recorded as an A in the book. 4 or 5 was recorded a B. 2 or 3 was recorded a C. If she could not prepare the solution, there was no grade. The worker was then paid on a pro rata basis. So let us say she had seen 300 people and 90% of them got an A, and an A was the equivalent of 5 taka or 5 rupees. It would be 0.9 times 300 times 5. The same for B, which would be 3 rupees. C would be 2 rupees. So at the end of the day, you both have an assessment of what mothers learned and what you should pay your workers. So you were getting 2 things for the price of 1. It turns out that this message was so effective that 10 years later, in some communities where they were doing work on education, they did a survey of children who were born around that time, and about 85-90% knew the message knew what to do. So this had now become part of the culture itself. So what do we learn from this OTEP program? Well, over a 10-year period, 12 million mothers were taught at home to prepare the ORS solution. The knowledge was transmitted to mothers by a female OTEP worker whose salary was based on what the mothers learned. Knowledge has persisted, and Bangladesh today has the highest use rate of ORT. What about teaching and learning? Well, OTEP workers were effective and innovative in part because their salary was tied to performance. They themselves, in the beginning, were not nearly as effective, so they were brought into DACA, to the ICDDRB, and were shown how effective this could be. Learning and use were linked to the OTEP workers because they then believed in their own message. If they don't believe in their message, they will not be effective communicators. Mothers learned because the message was tied to their experience and they field tested their own preparation. So what are the lessons then from this Brac experience with ORT and scaling up? One, again, you need this institutional vision, alleviate poverty, and a commitment to scaling up. That was the commitment from the get-go. You need to develop pilot programs with research and evaluation as critical components. You need to keep the interventions as simple as possible and train prior to scaling up and apply those lessons. Again, the extreme importance of down-to-earth and appropriate management. Evaluate and adapt, and lastly, advocate for your position. There's a nice quote from the great physicist Albert Einstein that everything should be as simple as possible, but not one bit simpler. And I think both in the DOTS program and in the OTEP program, they strove to achieve those results. Well, let me switch at this point and ask the following question. Could this system work for non-infectious chronic diseases, hypertension, diabetes, even HIV, which I haven't included here, but we could talk about? How could this be done? Well, taking a lesson from the Brac DOTS program, a bond could be delivered before therapy began and interest on money withdrawn on compliance. Patients could be paid for maintaining health, that is, blood sugar, blood pressure, and so on, taking their medicines. Treatment out could be tied to insurance. It's another possibility. You might apply this system for the first 2 or 3 years in a person's treatment, and this would get the patient to regularize their treatment. Again, community-based management by non-professionals, and follow-up would be required with periodic clinic visits. So this could be handled by ASHAs and others who are community-based to be followed up in a clinic maybe once every 6 months or something of that nature. Let me conclude with a few observations on the science of delivery itself. We need to deliver through the most proximate channels and achieve scale through simplicity. By creating a learning culture, by embracing feedback and failure. That is, we should not be afraid to fail, but in fact, the real failure would be not to learn from things that did not necessarily work. After all, life is not a dichotomous situation with success or failure. It's degrees of success that we're looking at. And how do we ensure that we will achieve the highest level of success, recognizing that we cannot achieve anything approaching 100% success. We need to build robust monitoring and evaluation systems. This is from a paper from Mustaq Chaudhry, who was one of the founders of the Research and Evaluation Division, and eventually became a vice director of Brac. What about lessons on taking innovation to scale? This is from Asif Aslam, who is the present CEO of Brac in an address to the Google Foundation in San Francisco. And he noted that innovation is a process of iteration and learning. You're constantly learning and evaluating and implementing. And this requires a degree of patience. If you'll go back to my earlier comments, we need to be careful that we don't rush things beyond where we can actually evaluate. You need to start by learning and focus on what needs to be reduced, not what needs to be added to the program. It's actually much more difficult to simplify than to complicate. Complicating is easy. Complicating can be done very easily by adding all sorts of things. Simplifying is not making something, it's not dumbing down, as we say. It's actually a much more difficult process. You need to get decision makers to pay attention. The goal is not improvement. The goal is improvement, but not total change. So these are lessons that he has and Brac has applied on taking innovation to scale. Let me lastly put in a couple of remarks about incentives, which are sometimes a contentious issue. In both of these cases, incentives were used. One in the DOTS program to incentivize the worker to find cases and to complete therapy, and also to incentivize the individual to continue on with their therapy and not default. There was an incentive there as well. And in the OTEP program, there was an incentive to the worker to do the best they could because her salary was dependent upon what mothers learned, once it had been shown that any mother could learn these messages. So you want to be as close to impact as possible. Incentivize outcomes and processes. Mix the indicators for quantity and quality. Whatever you do should be easily observable and possible to verify. You need to change indicators and incentives in response to changed provider behavior and according to epidemiologic needs. That is, you cannot be simply wedded to one kind of incentive system and ignore changes that are taking place. And speaking of which, I will come back to this in my final remarks. So here are some other thoughts from the Brac experience. Finding the technology is not as important as finding the right actors to deliver that technology. There will always be tension between a strategy and implementation, so you've got to be flexible. You're all with government, and it's clear that the government is critical in scaling and creating a scaling up environment. So the government of Bangladesh has been very involved in the scaling up of the Brac DOTS program by providing the drugs free of charge. You have to allow for failure. Failure is going to occur. I would probably rephrase this and say you need to think of success as a continuum, and not everything will be a roaring success. You need to elevate the role of practitioners as they are the ones who are delivering what it is that you are providing. This again is from the Stanford Social Innovation Review. Lastly, there are a couple of quotes I'm very fond of. One of these is by Louis Pasteur, who said that chance favors the prepared mind. What you're doing now is you're preparing yourself. You're preparing yourself to go out into the field to do projects. Secondly, from the Greek philosopher Heraclitus. You can't step in the same river twice, meaning that things are constantly changing, particularly in today's world where things move very quickly. And you've got to be flexible enough to adapt to those changes. It's not the same. You step in the river and you step out, you step in again, it's a different river. And that's the world that we all live in. So at that point, let me see if I can get out of the slide sharing. And ask if there are any questions that you might have. So thank you very much, and I hope that this stimulates a bit of discussion here. I will ask you to review the chats and to then address, Amrit, maybe you can do that or somebody else, and just to let me know what the questions might be. So thank you very much.
Thank you so much, Dr. Cash. I now request Guru to go through the chat questions and put across the questions.
Yes, Amrit, thank you for that. And good evening, Dr. Richard. I have a couple of questions that has been posted by my colleagues in the chat box and I've already collated them here for you. So shall I go ahead with the first question that we have here?
Please do. How much time do we have?
We have
I think 45 minutes, yeah.
Okay, so there were no rush.
Yes.
I didn't want to leave just a little bit of time, but give us enough time for a discussion.
Thank you for that. So can I go ahead with that?
Please.
Yes, thank you for that. And I have my first question here from my colleague Sankal. So his query is like, when we look at India, so India being the major part in the rural side, so how do we motivate doctors and the other healthcare staff to go towards the rural for work?
Well, I think there are lots of ways to motivate. First of all, just your profession should be a motivator. Hopefully, people who are in the healing profession will see this as something that is their calling and not simply a way to make as much money as they can. And I think the vast majority of care providers, from physicians on down, that is nurses, ASHAs, and so on, are committed to this. We need to make sure that we provide them with an environment where they can actually function. Nothing more depressing than being trained to do something and then going to a place and not having any equipment available, having health clinics dirty and filthy, no water, no sanitation. It's appalling sometimes when you go out and you visit a number of rural treatment centers and there isn't even a good water supply and no sanitation. And we're trying to convince people that this is something they ought to do. So I think at the first instance, we've got to provide those individuals who are on the front line with what it is that they need. I'm not suggesting an incentive system to a monetary incentive system like you do so many tubal ligations or so many of this and so many of that and you get paid. Those are wrong incentives, incorrect incentives, and have, as you know, led to a certain level of abuse. But there are other incentives. There are promotions. There are recognitions. All of us in your own profession being recognized by government, by others, by the community is a great source of gratification. And so we need to think about that. We need to think about how do we make people want to do something, which in fact, many of them, most of them want to do. Otherwise, they would not have entered that particular profession. There are exceptions. I mean, there are obviously people who don't do that. We're seeing that every day. But I think we go to I tend to be a glass half full person, as you can see, not a glass half empty person. Okay. Thank you.
Thank you for that. So continuing with the same with Sankal. So the second part of his question was related to the patent protection versus the generic medicine. So with regards when we are comparing it to the developing and the poor countries. So what is your take on that, Doctor?
I'm sorry, I don't think I understood the question.
Yes, let me come again. So with regards to the medicines that's being produced, so the patent protection on that. So normally the organizations, they try to have a patent on the medicines. And when we look at the generic medicines, so which are freely available. So what is your take on that part?
Well, there are international laws and regulations and so on. Let me leave that aside. The vast majority of medicines that people need are, frankly, in the generic field right now. And India is the largest producer of generic drugs globally. The big issue here, of course, in India is the quality of those medicines. There have been some recent books which have questioned some of the producers of those. And that's something that the government of India and the Drug Administration must pay attention to. But the vast majority of what people need are freely available. Let's look at the recent the recent crisis on COVID. There is a drug called remdesivir. The fact is, it doesn't do very much at all. It costs thousands of dollars, and whether or not the patent is held by the pharmaceutical company, frankly, in my view, doesn't make a damn bit of difference in terms of the health care that the vast majority of Indians will require. What India really needs is to make sure that there's oxygen available for people who have respiratory problems, that they are put in the bed properly on their belly if they have respiratory problems. But all of these drugs, most of them are of no use, like hydroxychloroquine or various teas or different preparations. Most of them are worthless anyway. And the one that has been shown to have some marginal impact, there may well be issues of patent and so on. I don't think that ultimately that makes very much difference at all. Not to the vast majority of Indian citizens.
Thank you for that. So the next question that I have is from Amit. His query is like, when we look at tuberculosis and corona, both are life-threatening. There are so many people dying due to tuberculosis every year. And now TB, it's also now moved into a drug-resistant disease, which is similar to COVID, wherein there is no vaccination for COVID at this point of time. But people are not scared of TB, but we are much afraid of corona. What could be the possible reason on that?
Well, that's a rather long and complicated question. Let me try to address that as best I can. I co-authored an article with Professor Vikram Patel, who's now who's on our faculty, but presently is with his own group in Goa, Sangha, in the Lancet in early May. And one of our great concerns was, with the whole COVID situation, is that the response to COVID was going to cause far more damage than COVID itself. Okay? That the lockdowns, and all of the impact of that in terms of reduced transport, keeping they were very good at spreading the virus of fear. Fear is also a virus. And people became so fearful that they stopped going to hospitals, even when they had symptoms of tuberculosis. And so referrals for tuberculosis have gone way down. People are not getting the treatment that they got in the past because they don't come to clinic or it's not being distributed in the community. There will be far more deaths from that, from decreased immunization, from decreased prenatal care, from all of the, what we call the bread and butter, the basic health needs. There will be far more mortality and morbidity associated with that than will ever be associated with COVID-19. Now, and I think data is already demonstrating that. In Bangladesh, India, and Pakistan, the deaths per million is pretty much the same. Whether you have a severe lockdown, lockdown light, whatever you do, the virus is spreading, but it's not causing the same mortality patterns that you're seeing in the Western countries. Not the least of which is because this is a disease that kills older people, people like me, people who are over 60, 65. Well, India is a very young population. Bangladesh is a young population. Pakistan is a young population. And and therefore, the number of people dying from these conditions will be far, far, far less per million than in the United States. The last time I looked, India, all three of those countries were 20 to 30 per million. The United States was 440 per million. Okay, that's about a 15-fold difference. So the concern that we had, and your questioner had, is what about these other conditions? Tuberculosis, I think people still are aware of it and fear it. The beauty of the Brac program is that it was community-based. It was active surveillance. Active surveillance means you go out and look for cases. You don't wait for them to come to you. You look for them. You seek them out. And then you can identify them earlier so that the time that they spread the infection is reduced. And you start treatment earlier and you ensure that treatment continues. Now, one could look at the COVID situation in somewhat the same way, and that is if you can identify an individual early who is certainly sick through contact tracing, you can use probably the most effective tool that you have, which is the use of masks. Masks or face covering, doesn't have to be a mask, it can be a bandana or something across your face, dramatically, in my view, reduces the spread of disease and the severity of disease. You combine that with hand washing, which is not always easy, certainly not easy in the slums of Mumbai or any large city, because soap and water is now often not available. But the simple use of masks itself around people who are sick or people who are sick, it will reduce the spread from person to person. It will protect the person who's not sick, and it will reduce the intensity of the infection. That's something that's really doable, is about as cheap as it gets, and should be extensively used, especially in crowded situations in a dwelling or outside, which, as you know, is extremely difficult. You know, in the Dharavi slums, how are you going to keep people away from other people? It's probably next to impossible, but you can help to reduce spread by using facial covering, being outside, and so on. And as you have seen, the outbreak in Dharavi seems to have come down. But again, early identification, directly observed therapy, are ways that we can help to reduce the burden of tuberculosis. And we should not allow our response to something else to prevent that from happening. Okay?
Yes, doctor. Thank you. Now, the next question is from Bipin. Doctor, what is your input on telemedicine in rural India? And like, what are the measures the government needs to look into when it's going towards telemedicine?
I'm certainly no expert on this. It's clearly been used more than this outbreak has led to a much more extensive use of telemedicine. Of course, individuals have to be able to use that system. I know that, for example, the Aravind Eye Hospital in Madurai has made great use of telemedicine in terms of diagnosis and so on for a number of years now. So I think it has a possible value to diagnose certain conditions. But I think ultimately, they used to say most people have what most people have. That is, the very common things, I think, still can be dealt with in the community. There are certain conditions, obviously, where getting a telemedicine connection is important. But remember, at the other end, you can diagnose and you can prescribe, but there has to be somebody at the other end of that dialogue who has the medicines and can prescribe. So you could, that's why I suggested that the model for hypertension and diabetes and so on, certainly you could do it, but you have to have somebody at the periphery who can measure blood pressure, who can measure blood sugar, and then convince people that continuing care, because with chronic diseases particularly, we don't cure many things in medicine. We cure a lot of infections, but most other things we don't cure. We create a situation where people can live with what they have or reduce the risk of that. So you can reduce the risk of obesity and diabetes and so on by avoiding sugary drinks, things of that nature. But when somebody gets diabetes, it's a lifelong condition. How do you manage that? How do you get them to change their diet? How do you get them to exercise more? How do you get them to look after themselves? Because the condition itself is not going to be cured. Hypertension is not going to be cured. What you want to do is to make sure that people maintain a blood pressure that is safe through diet, through exercise, through simple medication. Things should be as simple as possible, to requote Professor Einstein, but not one bit simpler. Okay?
Yes, doctor. Yeah. Thank you for that. Now I have the next part of the question by Rishi. So his query is with regards like, how can the distribution of the quality healthcare be possible to poor countries or maybe the rural areas as well?
How can the quality of healthcare be assured? Well, remember that health is still a state function in India. It's not a national thing. And so I think state governments need to look at measures of quality of care. What constitutes an appropriate measure of quality of care? Now, obviously, there are great differences throughout India. Kerala being sort of on one end of the spectrum, and I don't know, rural UP, maybe Eastern UP on another end of the spectrum. I think that by keeping guidelines straightforward and as simple as possible, we can ensure quality for the most common conditions, not for everything. But I think by setting certain guidelines and standards and then applying them and also having a good, what shall I say, good evaluation. I don't think there's been one physician in India who's lost their license because of malpractice. I don't think there's, maybe you can count one or two, but the profession itself has got to think about how do you keep bad apples out. And there's no question there are physicians or nurses or quacks and so on who are causing great harm and damage. How good has the profession been in getting those people to lose their license, to lose their ability to practice? I remember when there was a 20 or 30 deaths, I think it was in Chhattisgarh, from tubal ligation, simple procedure. I don't think anybody has ever been brought to book for what happened. What is it? Was it an act of God? Obviously not. It was somebody using the wrong medicine, using the wrong technique. Something went on and 30 people died and nobody was brought to book on that one. I find that quite incredible, unless things have changed since I was last there. There's an old saying, we have seen the enemy and it is us. So in many of these situations, we have not taken the initiative. We have regulations for pilots. We have regulations for drivers. We have regulations for all sorts of things. And if somebody doesn't follow those and is egregious in their behavior, we have ways of dealing with it. Medical profession has done a very poor job of dealing with people who do not provide good quality and in fact provide harm, cause harm.
Thank you for that. Now I have the next part of the question is from Amrit, and I'm clubbing it with Nishi, who's the concern is with regards to the ASHA workers, wherein ASHA workers are already being bombarded with the workload of giving various data, but can we empower ASHA workers to treat the common diseases? So what is your take on that, Doctor?
Well, I think if the treatment is simple, and treatment of TB is simple, as I pointed out, and there are very clear ways of doing it, and there is a good backup. That is, with a lot of community health worker programs, people are trained, in my view, far too long, and then they're sent out there to carry out the work, and there's no supervision, and there's no continual evaluation. No business would do that. If you're selling whatever soda you're selling, or chupples or matches and so on, the distributor is also checking in on all of the shops that are doing that, and they do it periodically. So if you're going to send the ASHAs out there, I believe that frequent, short re-education programs are important. I don't think that the initial training need be that long. If you have frequent re-education programs, and you continually evaluate them on some very clear metrics. The metric should be something that relates to what they're doing and is important, not simply down there to fill out a sheet. I remember a friend of mine was asked to, many, many years ago, to try to simplify the metrics of a primary healthcare system. There was something like 30 forms, one for this, one for that, one for this. And so he, after many months, simplified it, and he got it down to one form. And so what did they do? They had the 30, and then they added the 1. So now there were 31 forms. Well, that wasn't the purpose of the exercise. The purpose of the exercise was to reduce the 30 forms to one form. They ended up with 31 forms. So I think simplifying, I want to again emphasize, is not easy. Simplifying is difficult. It's difficult because you have to make a decision, what stays and what goes. But it's a very critical decision because having people collect information that is no value, and they see no value, and so when they see no value, when there's no feedback, they stop collecting it, or they simply fill it in. And so you'll look, and every month it's the same number, 15, 15, 15, 15. That's the first tip that something is amiss. So people have to see that what they're collecting is useful. They need feedback. You know, we're no different. As students, we want to know, is this, what am I studying for? Is this, am I studying something that will be of value, of use? And then how will they evaluate that? Nothing is more aggravating to a student than to see a question on an exam that has no relevance whatsoever to what they've been studying. And they see no linkage to it. And that will be forgotten within minutes after leaving the class.
All right. So now I have this question from Jayant. He's asking, like, Doctor, with regards to this pandemic, COVID has taken away the attention. But with regards to, when we compare it to the other illness which needed critical care, how has this impacted on the other illness?
Well, as I tried to indicate earlier, unfortunately, not COVID itself, but the response to COVID, okay? The response to COVID, the governmental response to COVID, or the public's response, has led to certain issues. Immunization rates are down about 70%. TB treatment is down. Fewer people are coming to clinic because of heart problems. Fewer people are coming for other health problems. And so what has happened is two things. One, fear was imparted on the community. Don't go there, don't do this, don't do that. Stay at home if you have this. That was appropriate. You don't want people flooding clinics with COVID symptoms, most of which are going to get better anyway and don't require any hospitalization. So yes, that was a good thing. But at the same time, you still have to provide basic health services, not things that are unnecessary. And those basic services, many of them, in fact, could have been provided in the community by ASHAs or by a community-based system if that system was functional. Unfortunately, it wasn't functional in many places, and so care was essentially cut off. But there have been, and this is not just in India, in many other parts of the world, basic services have suffered because of this obsession with COVID-19.
All right. Yeah. Now I have this question from Mayank. Earlier you were talking like to keep the things simple when we look at medical care. But can we use technology in providing the medical facility to the major population of the India when we look at who is illiterate? When there is a illiterate population is higher, so can we look into, how do we look into that?
Well, I think technology has a place, obviously, and we are increasingly moving towards greater technologies and so on. But I don't think you can take out the human element. You know, Bangladesh is certainly as poor as many places, many states in India. Obviously, India is a patchwork of all levels of development and so on. But let us compare Bangladesh to West Bengal or parts of Bihar, UP, and so on. We did a small study some years ago comparing Bangladesh to West Bengal. which is done better than most of India, by the way, and found that at the time of partition, 47, uh, East Bengal, as opposed to West Bengal, had much, much, much worse health statistics because all the wealth was in West Bengal, it was in Calcutta and so on. Bangladesh was sort of the providing the jute and the rice and so on, but the wealth was in Calcutta. But since their independence in the 70s, they have increasingly developed statistics which are almost identical to those of West Bengal. And one of the why is a very interesting question, is a question that I'm not sure anybody has yet provided an adequate answer, mainly because doing cross-border studies is not something that's easy to do because of the politics, unfortunately. But we concluded that civil society was stronger over on the eastern side than on the western side. And that people, because of the strength of some of the NGOs and other communities, people were more civilly engaged in their own situation in terms of health workers and schools and so on. Now, whether this is true or not, I don't know. But it's interesting to compare something like open defecation. In India, it's still around 35%. In East Bengal, Bangladesh, it's around 4 or 5%. Why is there this huge difference? And it is a huge difference. It's not a matter of 1 or 2 percentage points. Very interesting question. Very interesting. And is this related to local initiatives? Is it related to government? Is it related to culture? There are all sorts of, I don't want to get into that issue, but it raises interesting questions. So I think that I'm very interested in comparing likes to likes. There are 3 areas, for example, in India or in South Asia, let me look at South Asia, that have done much better in terms of COVID. And those are Kerala, Sri Lanka, and interestingly enough, Nepal. Nepal, Sri Lanka, and Kerala. So what is it different about those situations, and what can we learn? Unfortunately, and I've been working in South Asia now for over 50 years, there oftentimes is a sort of competitive thing. If I do well, that means you don't do as well. This is not a competition. This is a way that, how do we take lessons from all sorts of places and apply them to our situation? So technology has a role to play. But I think in India today, at least for the foreseeable future, it will still depend upon a person-to-person interaction, if for no other reason than to interpret what that technology means. So the technology is important, but there still needs to be somebody at the end of the queue saying, well, what does this finding mean, and how can I operationalize it? So we can do better diagnosis. Certainly, we can spread messages much easier. We can, there are lots of things that technology can do. It can give us much greater access to money, issues of credit and banking. There have been remarkable changes in terms of using technologies to do this, whether it's Bcash in India or some of the programs in Andhra and so on, remarkable stuff. But I think that we've got to be careful that we don't substitute that for still that human interaction, which I believe still is rather critical in interpreting some of that information that we're getting. But that said, technology has done wonderful things and will continue to do wonderful things if we use it sensibly.
Thank you.
Just to interject here, if we can ask Anil sir to ask his question. I think he had typed one question there. So Anil sir can go ahead and ask his question to Dr. Cash, if he's around.
Yeah. Hi, thanks, Amrit. Dr. Cash, thank you for a wonderful lecture. And it's a pleasure to have heard you and about many things that we perhaps have observed and noted, but your lecture has illuminated it even further. I just wanted to kind of raise a point about the financial bond and as to how the strict enforcement of the bonds is very critical. And given the kind of social and political forces at play in many aspects, do you feel hopeful that if we could enforce it strictly, even in the Indian context?
Well, that's the financial bond question is a very interesting one, and I'm glad that you raised the question. I think ultimately, the reason it worked there is because there was trust between the program, between Brac, between the Shasta Shebeka and the community. If there is no trust, you can't do it. You have to be community-based and there must be trust. If trust is lost, then who's going to put up the money? They say, well, yeah, last week somebody came and took 200 taka and I haven't seen him since. So it requires long-term involvement and requires trust. And government and local government, when they squander trust, they squander one of their most important resources. So I'm not suggesting that this could be done anywhere and everywhere. It can be done in those situations. And remember that also in the programs that I mentioned, it wasn't just a health program. Brac is providing microcredit, rural schools, cooperatives, feed stores. It's a billion-dollar operation now. Of course, at that time it wasn't. But trust is really important. And if you don't have trust, you can't do these programs. And so I would say that is one of the, and in our country, I mean, I just take a look at our own response to the COVID-19. Unfortunately, in my view, the government has lost, particularly the top of the government, has lost the trust of the population. So when even if they give good advice, there are many people who say, oh, yeah, I know who these people are. The only reason they're doing it is because they want to get reelected, or they're trying to make money, or they're pushing their political brand and so on. So if you don't have that, very critical element, you can't do a lot of this stuff. And so I would say a bonding program has value if there is trust between those people delivering the services and those people who are accepting the services. Remember, the Shasta Shebeka is based in the community. She can't run away. she can't abscond. She's there. And so that's very important. It was very important that they had seen that the schools were working. It was very important to see that the microcredit program was working. And it takes a long time to develop that trust, and it can leave very quickly. So it's very, very, very important. And it's very important as you as IAS officers and managers and so on, that trust be there. So if you promise something, then you promise it and you deliver. That's far more important. So those who deliver are more important than the technology itself, as I noted. I don't know if that answers your question.
Yeah, thank you. Thank you. I think that's a very important point. And like how it is across governance, but more so when it comes to being able to enable it through the community. I think trust is something that is very vital.
Absolutely. And it takes time to develop it.
Yeah. Thank you.
One question
Thank
was
you.
asked by Kalyani there. So
I was just going ahead with that. Dr. Richard, like now I have a question from Kalyani with regards to the nutrition.
Yes.
So the nutrition being the major portion for everybody's intake on daily basis, and many parents don't consider that as being the major responsible factor for the illness down the lane in the future. So when the things get critical, that is when parents realize the things. So can you just put some light on the things like how important the nutrition factor is?
Well, I think obviously nutrition is quite important. And as you know, India has a very a disturbingly high level of stunting in the community. But I have to say that over, at least, again, I'll go back. I'm sorry to keep going back to my Bangladesh experience, but but I consider all part of the South Asian experience. I have seen severe malnutrition going down dramatically over the years. That is, and one of the reasons for that is because we've done a very good job of reducing childhood illness. The high rates of immunization have been very critical in reducing childhood illness. When I went to Dhaka, and again, this is the data I know the best, the infant mortality in 1967, wow, 53 years ago. I know I don't look that old, but I'm afraid I am. It was 155, 160. It's now down in the low 30s, okay? That's a huge, huge difference. That's a huge drop. And with that drop, we have seen a dramatic reduction in severe malnutrition. Now, stunting is still there. And there are causes for that, including low birth weight, in some areas where there is poor water and sanitation. It may be related to a low-grade infection in the intestine. There are multiple causes. I think we've also, though, come a long way in convincing mothers and caregivers of the importance of good meals to children, adequate meals to children. And so I think that over time, it's been slower than I suppose we'd all like to see, but there has been an increasing improvement in nutritional status of children so that there are now pockets where it's higher than general. I don't think that you should become obsessed with so much with the numbers as to look at whether or not children are healthy, whether they're going to school, whether they're learning, whether they're getting the meals in school and so on. I think that maintaining a good primary healthcare system and maintaining very high levels of immunization are absolutely critical. And improving water and sanitation, all the things that you're engaged in are critical. I think all parents want their kids to do as well as they possibly can. Clearly, there are certain kinds of foods that we should be discouraging, like soda pop and things which don't have much nutritional value. That's certainly something that a more national governmental approach might have some value. But I have found over the years that parents are very concerned. They want to do whatever they think is useful within their means, within what they have. And unfortunately, in many places, they don't have the means. And so we have to provide that. We have to provide people with the means so that they can achieve that which they know. I've been convinced over the years, as I say, that most parents, they want the best for their kids. Of course they do. Why wouldn't they? And so how do we provide them with the tools for doing that? Where they are under grinding poverty, where food should never be, in my view, an issue. Nobody in today's India, I don't care who they are, should go to bed hungry. There's plenty of food in India. There's plenty of food. It's getting the food to the people who need the food making sure that it's distributed, but it's not a shortage of food. Those days are past. It's not a shortage of food. It's getting food to people, the right kind of food to people on a regular basis, so that nobody, children, adults, I don't care who they are, should go to bed hungry. Things have changed. There have been dramatic changes over the 53 years I've been coming and going. In fact, I gave a talk the other day in Orissa, on goings and comings. And I can count at least 6 diseases that aren't there anymore that were there when I first came. Smallpox, polio, tetanus of the newborn, guinea worm. There are a whole bunch of diseases that have disappeared. We're focusing on the new ones, but what about the old ones have gone? And we've done a pretty good job with it. Not as good as we should have done, not as fast as it should have happened, but of course my glass is empty now, but so I'm an optimistic person. And the means are there. The means are there. It's not an issue of national poverty. National distribution, yes, but not national poverty.
Exactly.
Well, I don't want to keep you beyond your next class or whatever you're doing, but I'm happy to stay as long as you want.
It has been a very engaging discussion, and like we are loving the discussion. So any further questions, Guru? Or
yeah, one last question. I'll just finish the question.
Okay, we'll take one last one here. Okay.
Yes, Dr. Richard, this is my personal question. From one of your videos that you had said, like, healthcare is basically the peace of mind. So that's what the statement that you had given in one of your videos when I was looking at. So what is your state when we look at India? How far are we from achieving that?
Achieving peace of mind. Is that what you want? That I can't speak to. That's sort of an individual. I mean, there are many traditional, meditation and so on that are designed to achieve peace of mind, and that's. But I think that we need to create situations, be it in India or wherever, where people feel that we're all going to die, I'm afraid. That's the first thing they taught me in medical school, that life is not, doesn't go on forever. But we should not have to suffer unnecessarily, and we should be able to fulfill whatever our potential is in terms of, not that everybody's going to be a billionaire and so on. No one is asking for that. They simply want to feel that they have a place to stay that's safe. People want to have security. People want to practice their religion, whatever it be. People want to have a feeling of security. They want to have food that they can put on their table. They want to not suffer disease or illness unnecessarily. And I think that's what people want. That's what you want. That's what everybody on this webinar wants. And the challenge to government, to society, because it's not just government, is how to achieve that. How to make sure that we achieve it at the same time we don't hurt others in the process. I could go on and on and on, but I won't because we'll do that another time. When I'm next in Bangalore, hopefully I'll be able to travel there again soon. And I have great fond thoughts of Bangalore and many ethics workshops I've given there, nutrition workshops. So I look forward to coming back to your fair city, which is probably has less pollution now since you don't have as much traffic. Maybe the air-conditioned city of Bangalore is returning, right? the things. You've reduced your pollution, and it's back to where it was. We've often stayed at the Taj Hotel, which has a beautiful botanical garden. One of my favorite places in all of India to come to. And maybe now you can restore some of that. But it's been a pleasure, and I wish you all well, and maybe we'll see each other somewhere else sometime. And I'd like to thank you for hosting this, Amrit, and others at IIM. And I hope that I've been able to at least address some of the issues that you were interested in.
Yes, Doctor. I mean, the session was very enriching, and yes, it was a real pleasure meeting with you. And on behalf of IIMB and all the participants, I thank you for being so patient and allocating your precious time to us. And you're definitely given us a new dimension, because as policy students, we usually focus a lot on policy development. But your inputs made us understand how important implementation is, and how simple implementation could be effective with your experience. So I am sure that the day's learnings will go along in our career. And I thank you so much for your participation and the inputs that you've given to us. Thank you, Doctor. Thank you so much.
If there are any questions that come up that I have not had a chance to answer, maybe they could send them to you, Amrit, and I'll do my best to respond.
Dr. Richard, just to let you know, now I know what it means when people say we can't have enough of cash. Thank you once again. Thank you.
Okay. Thank you all very much. I appreciate it.
Thank you,
Doctor. Thank you so much.
Thank you,
Thank you,
so much.
sir.
Thank you.
Thank you.
Thank you. Thank you.